Dr. Leonard, go ahead.
So good day. We're delighted to be with you. What Alan and I are seeking to share with you today is really the culmination of probably 20 years of work within the world of patient safety and quality improvement. We've had the privilege of teaching in the Institute for Healthcare Improvement Patient Safety Officer course since its inception, and trained over 2,500 patient safety officers. And as we've done that, and we've had the privilege of working with those folks, working within healthcare systems, we really realized we need an effective functional framework or roadmap to guide people in this work. And that's what we are going to share with you today. Next slide, if you could, Chris. So,
has this slide not advanced yet?
It is not advanced, yeah. There we are. Thank you very much. So I want just very briefly kind of give you a sense of who the folks are that are talking to you on the phone. Alan started in patient safety within the Harvard Hospital, so I started in patient safety for Kaiser Permanente and spent 10 years doing that across the organization. And we've been at this a long time, so we've been in conversations around things like team steps and crew resource management, long history working with the Institute for Healthcare Improvement. Alan essentially initiated walkarounds at the Brigham and Women's Hospital some 20 years ago, and what we're going to share with you is kind of the evolution of our work. Next, if you would, Chris. So our goal, in essence, in the next hour is to provide a very practical framework for you that can be applied in any setting, whether it's a neurosurgical ICU, an office practice, or home care, or pharmacy, to really talk about basic concepts of high reliability organizations in a very practical manner. And if we think through the basic tenets of the Joint Commission model, effective leadership, what is that? What does it look like? What are the actions and behaviors associated with that? Culture of safety. We've had a deep interest in culture for the last 20 years, have measured culture in a couple thousand hospitals. And how do you actually drive an environment of continuous learning and improvement? Improvement is not an inherent skill among all our really kind of dedicated, very, very smart healthcare folks, because it was not something that was kind of baked into our DNA, but it's essential and a really key piece of organizational evolution development. And then to offer you some very practical tools and insights. Next, if you could. So we're going to share a framework with you that we published with our friends at the Institute for Healthcare Improvement. And the white paper is on the left side. You can download that for free from the IHI, or we'd be happy to send it to you. And in essence, what you're seeing on the right-hand side is that model. Now, obviously, everything is within the service of patients and their families. Pretty sacred trust that people entrust their lives and their well-being to us. And if you think about this model, there's essentially three pieces. From about 10:30 to about 4 o'clock, those are cultural attributes. And we've really come to strongly believe that culture is the glue. It's what kind of allows groups of very smart people to have high degrees of social agreement, work collaboratively together, be reliable and consistent in the care they deliver, and create value in learning every day. Leadership is a critical component of this, and we'll speak to this in more detail. And then, in essence, the pieces in the blue essentially relate to kind of the processes of improvement, measurement, continuous learning, testing. Now, the reason these are all there is we really came to appreciate over time that if you focused on one or two things, so we're going to do leadership training, we're going to do teamwork training, we're going to do lean, and you did that in isolation, that was in essence well-intentioned, but it was a science project. And it was not sustainable improvement. It was not sustainable learning. So the reason we have this framework is that when you go into any setting clinical or non-clinical, which could be a 2-person office practice or a 1,000-bed hospital, these are the things we look at. These, in essence, the same way clinicians look at organ function in patients, whether that's pulmonary or cardiac or renal or GI. This is how we kind of pay attention, assess, and learn about the places that we're working, that we want to drive improvement. And again, like organs in a patient, these all have to be somewhat healthy. They don't have to be normal or, have high degrees of function, but if there's 1 or 2 or 3 that are pretty dysfunctional, it's very hard to kind of drive sustained learning and improvement. And it also provides us a very clear roadmap to move forward and do this work. Next, if you would, Chris. So one of the things that we've really come to appreciate over time is this concept of a cultural maturity model. And this has been around in the high reliability world for probably 40 to 50 years. Started in the 80s with a gentleman named Ron Westrom. People have been involved in this over time. And it's essentially kind of evolved as people really think about organizations outside of healthcare, within healthcare, as how do they culturally mature in a way that they move from unmindful to generative. And let's spend kind of a couple minutes on this, because as we look at the various components of the framework, whether that's leadership, whether that's psychological safety, whether that's teamwork, whether that's learning and improvement, we can rate all of them on this maturity scale. Unmindful is essentially showing up and trying hard. And historically, if you think about how we've trained nurses and doctors, we've used the individual expert model. And that says we put all these exceptionally skilled, dedicated, highly trained people together in very complex environments, and they'll just figure it out. Well, the world of healthcare, the care we deliver today is far too complex for that to be actually a successful solution. And what we really want to do is to collaborative work, highly skilled individuals working collaboratively in complex environments. So as we move from unmindful, the next piece of this is reactive, where we're kind of learning every time something goes wrong, we kind of blow it up. Systematic is where we have pockets where we get it right, but that's not kind of uniform. Something really starts to change when you get to be proactive. And if you think about being an expert, what happens when you come in the morning? You walk into a situation, your brain very quickly says, I've seen this before. Is it good? Is it bad? You do the same thing with patients, right? You walk in a room, look at a patient, and your brain goes, really sick, a little sick, not sick, because you're pattern matching and you're kind of using that prior experience to say, I've seen this before. Did I like it the last time? What is it? What's the problem we're trying to solve? Where are we going to go? What does success look like? And a critically important question, and that is, where can we get into trouble? Where can we fail? Which is a basic aspect of high reliability, is not assuming everything's going to go well, but ultimately saying, where can we get off in the weeds? Where can this go wrong? Let's think ahead and let's actually mitigate or preclude that risk. So if you think about your daily experience, being reactive is coming in, not knowing the plan, having your day full of surprises, interruptions, distractions, and really avoidable surprises, and that's playing defense. And that's not only exhausting, but it puts us at risk for making mistakes, because we know when humans are interrupted and distracted and trying to multitask, they make more mistakes and they forget things. And that's certainly evidenced by trying to drive your car and talk on your cell phone, or texting and driving, or even texting and walking. So the question is, how do we move from that to being proactive, where we come in and we play offense? And you think about highly performing teams and organizations, they come together, they think ahead, they look at the environment, and they say, what do we see? What are we going to do? Who do we need? When are we going to need it? And how do we expect this to unfold? And it's not only a lot more fun, and actually, when you work that way, you kind of walk out of the hospital or walk out at the end of the day with a spring in your step, but you deliver considerably better care. So thinking about this maturity scale, next slide, if you could please. One of the things we'd like you guys to think about and actually have you tell us is, where do you think your organization is on this maturity curve? And I'll hand that to you, Chris, to help with that.
Thanks, Dr. Leonard. We've made that poll available to you if you can take a moment and fill that out. Again, where do you think your organization is on this maturity curve? Option 1, unmindful. Option 2, reactive. Option 3, systematic. Option 4, proactive. Option 5, generative. We'll also remind you, you can see the slides in the handouts pane, and you can ask questions in the questions pane of the control panel. All right, here are the results. The results are 2% said unmindful, 49% reactive, 29% systematic, 17% proactive, 2% generative. Dr. Leonard, what do you think?
I think these folks are very insightful. And let me give you an example. Alan and I and our group 4 years ago assessed 30 community hospitals for the state of Massachusetts because they're obviously very kind of mindful and concerned about the sustainability of high quality community care in an environment where lots of things are changing, a lot of systems mergers, et cetera. And in fact, your answers were very, very similar to what we found. We found 4 out of the 30 hospitals, essentially 13, 15%, were proactive to generative. And we found the overwhelming majority were living down and reactive, but certainly there were places where there were kind of pockets of kind of getting it right. And we certainly know that culture lives within organizations at a unit level. And so you can find some places, whether that's obstetrical unit or radiology or GI or a clinic, where these people really seem to be well organized. They work collaboratively. They're playing offense, but they're working in an environment where that is not, shall we say, consistent. And so, I think part of the value of having a maturity scale and a framework is essentially you can kind of say, here's where we are, where do we want to be, and what are the explicit actions that we need to take that are visible, measurable, and sustainable to kind of move, because you cannot ultimately be successful in a reactive mode. I mean, you have all these wonderful, smart people who work extraordinarily hard, and I mean, the most dedicated people in the universe, but that ability to come together and think ahead and play as a team is absolutely critically important for the care and also for the ability to deliver safe care. I mean, one of the things we hear time and time again is, well, people change at different times. They come in, their shifts are not overlapping or are overlapping. We don't get together, we pass on things. We can't figure out how to get together and spend 5 minutes. I mean, I was in an intensive care unit 2 days ago, and, the doctor's coming around, but they don't talk to the nurses. And so, I think what we would argue is you're too busy not to do that. And taking that 2 or 3 minutes to talk to each other and say, what do you see? What do I see? What do we think's going on here? Where is this going? And what does success look like? And where can we get into trouble is really critical. Now, a really important piece of that is if we think about the difference between novices and experts. If you're expert, if you've done this for 5 years, 10 years, 20 years, you have a huge library of experience in your head. And you've seen patients or similar situations hundreds, if not thousands of times. You can walk in a room and in about 5 or 10 seconds, your brain very quickly, with about 90% accuracy, says, good movie, bad movie. So what happens when we now are in a situation where the pace of care delivery is ramped up, the complexity of care delivery is increasing all the time, and we have lots of new nurses and new people in these complex situations? What's the blind spot for the newbies? The blind spot for the newbies is they're wonderful, smart people, but the library is pretty empty. So they can walk in rooms and look at situations that would be obvious to the expert, and they don't recognize it. So an inherent value in coming together for 2, 3, 5 minutes is the ability to kind of think out loud together. So I'm an anesthesiologist. If I'm standing in the recovery room and somebody's concerned about somebody's breathing, it's very easy to say, look, they're not retracting, they're speaking in full sentences, they're well saturated, they're breathing 22 times a minute. These are the things that tell me they're doing well. Any of those things change, call me. And so what we do is we create predictability. And one of the things that's really, really a basic concept of high reliability is anything you can make predictable, make it predictable so that the experts can manage what's unpredictable. And what we want to do is remove avoidable surprises. So this is where we find kind of this logic, this model, this way to kind of think about cultural maturity as something that is actually quite valuable. The other experience we had years ago as we kind of started socializing this cultural maturity model is you could take a slide like this into a room of caregivers or managers, physicians, and have that conversation and say, in our unit, in our hospital, where do you think we are today? And it's pretty amazing how people lock into it, which then kind of grounds you and says, here's where we are today. Let's think about where we want to be. Let's talk about the short list of explicit actions we can take to help kind of move us, right, move the ball down the field. Next slide, if you would, Chris. Got a little bit of a delay here.
The title says avoidable patient harm. Is that what you're seeing?
No, it hasn't moved on my screen. I think we have a lazy PowerPoint. Every time we give it a pause, it goes to sleep.
Others are seeing this, so if you want to speak to it.
Okay. Yeah, let me just do, give me just 1 second. I'm going to do that. So one of the things we know is despite, you know, the most skilled, well-intentioned caregivers in the universe, the rate of avoidable harm today is really just not acceptable. And we know from surveillance and trigger work that's been very systematic, the work of Stan Postotnik, the work of Don Kenneally of Baylor, Lee Adler at Adventist, et cetera, our friends, Alan Frankel and others at IHI, that fundamentally 1 in 3 patients admitted to an American hospital has something happen to them we wouldn't want to happen to us. And that's the ability to kind of get off into trouble. When we look at patients who experience serious harm, there are error chains. It's almost never one thing that goes wrong. It's a series of 10, 15, 20 things that are linked together as that error chain, as that snowball starts to roll down the hill and create the avalanche. And so, you know, that's a lot of opportunities to go the wrong direction. We do know that roughly 1 in 10 people admitted to our hospitals are injured or harmed to the point that they stay in the hospital longer and go home with a temporary or permanent disability. So that's not minor stuff. I mean, that's kind of getting hit by the pickup truck. We also know from some very good work that our friends Don Kenneally and Lee Adler did with the Office of Inspector General from HHS, that roughly 2/3 of those events are either avoidable or ameliorable. And what that means is if you detect it early and you act on it, you basically put out the brush fire instead of the forest fire. So again, you always want to have a plan, right? Because if you don't know where you're trying to go, then you're much more likely to not detect when you're going in the wrong direction. And then we get into failures of recognition that get us to the edge of the cliff. And then we get into the issue of are we going to effectively rescue that patient? So there is very fundamental opportunity. When we started the rapid response work some 15 years ago, what did the literature tell us? 70% of the patients who experienced cardiorespiratory collapse in American hospitals had documented evidence for an average of 16 hours in their chart before they fell off the cliff. So the ability to kind of know where you're going, know if you're going the right direction, wrong direction, and detect early that, you know, this doesn't seem to be quite right, or this isn't exactly what we bargained for, and to intervene is absolutely critically important for the delivery of safe care. Next, if you would, Chris. So let's talk about the role of senior leadership. And senior leadership is absolutely critical. When we think about and share the experience of kind of wandering around, learning in these Massachusetts hospitals 4 years ago, what was the quality of all 4 of those hospitals that we said were either proactive or generative? Senior leadership was physically present every day, walking the hallways 2 to 3 hours. And you would talk to people in the hallway, and they would say, you know, Frank's the CEO. I see him in the hallway every day. He knows about my kids. I know about his kids on a first name basis. I would never hesitate to go to him. And you would say, if you talk about an issue or a problem or a defect, or you don't have it, it doesn't work, you can't find it, and you go have that conversation, what is your degree of confidence that it's going to get fixed? And they say, I'm extremely confident. And that whole concept of dialogue, interaction with leadership in a way that leads to visible improvement and feedback is the hallmark of very high performing organizations. And just think, as you look at the slide, you know, what dynamic do you guys exist in? We've been in places where you can talk to frontline caregivers. We kind of never see them. Again, reactive. Something bad happens, all the suits show up. Where you want to be is up in proactive and generative, where there's systematic engagement. It's not transactional. It's building relationships. It's dialogue. And there's continual learning and feedback. That's critical for habitual excellence. And we certainly have seen that a number of places. And then you get into this conversation of, oh, well, we're too busy. I don't have time to do that. You know, you're too busy not to do that, right? So it's critical to be able to align senior leadership, middle management with the people at the bedside, because if you don't do that, often the people in senior leadership positions, you know, they're kind of not solving the right problems, right? I mean, think about Toyota production. The hallmark of the Toyota production system is frontline interaction with managers and leaders. You raise your hand on the production line and somebody's there in 5 or 10 seconds. So there's this continual cycle of learning and feedback. Next, if you would, please.
I've advanced.
Thank you. So here we're looking at some culture data. One of the things we do a lot of is measuring culture. And we're looking at some data from our SCORE survey that we developed with our friends at Duke. And we're looking at a very large hospital. So this is about an 800-bed hospital. And every line on this is a unit within that hospital. And we're asking a very simple question. So green is positive, 5-point Likert scale, 4 or 5, neutral, a 3, not so sure, negative, no. The values of facility leadership, the values of our senior leaders are the same values of people at the front lines. So we have alignment within the organization. What we see here is something we see all the time, which is there's tremendous variation within the same building, because we know culture lives at a unit level. But we can also see within the walls of that building, there's some very functional units where they're 80, 90, 100% positive. And then toward the bottom of this, we can see some units where that's less than a coin toss. And so really understanding that dynamic, that interaction, is there a systematic process or is there not a systematic process, is really critical for success. We also think, what are the explicit actions that could be taken to move this forward? And when we look at this data and we feed it back at a unit or an organizational level, one of the real takeaways on this is look at the yellow. because those, you have the people that are positive, and you can build on whatever you're doing right with them. The people in yellow are neutral, and that's the low-hanging fruit. It's much easier to convert somebody who's neutral into the positive category than it is to move somebody who's negative to doing that. Next, if you would. So I'm assuming you've moved ahead. I seem to have a little bit of a lag here.
Yes, I have.
Yeah, so let me show you kind of the science behind this. And I'm going to show you a study that we published a year ago of cultural data. This was 17,000 people across 30 hospitals in the state of Michigan. We've had the privilege of doing a lot of work with our friends in MHA over the years. And so what you're looking at when you're looking at these kind of collections of 3 bars is we're looking at specific areas of the survey or domains: learning environment, the ability to identify and fix things, the quality of local leadership, teamwork, safety, burnout. Also looked at personal burnout because we're very interested in that as a research issue, and then also qualities of work-life balance. So because we survey electronically, we asked 2 questions at the beginning of the survey. Do your leaders participate in walk-arounds in your organization? 10,000 people said yes. And then the second question was, did you get feedback on the issues you raised? And 4,500 said yes, and 5,500 said no. So if you look at this and you think across the mean, which is the blue, the people that said, I got feedback when I raised my hand, somebody listened, somebody cared, somebody did something, and I got an answer back, are dramatically stronger scores. And keep in mind, you literally need about a 5 to 7 point difference to be statistically significant. And the difference between getting feedback and not getting feedback and qualities around learning environment, trust that when we identify things, they'll actually get addressed and fixed, are over 30 points. The other take-home message from this is don't ask people what they think if you're not going to come back and talk to them, because we can see that the people who did not get feedback went backwards. Next slide, if you would. So if we think about qualities of local leadership, you really want to be up into proactive or generative. And it cannot be down and reactive where if I'm working with the right person, it works. Leaders have to model the values of effective leadership. They have to build trust. They have to listen. They have to provide feedback. Next, if you would, Chris. So here we're looking at some cultural data. And one of the things we know, because we just looked at that study, is the ability to consistently get feedback is key. And the reality is we can see within the same hospital, some units do that extremely well. Some units do not do that well at all. And that's absolutely critical. Next, if you would. So one of our learnings, and this came from working in very large organizations with our friends like Mayo and NYU and others, is that when we looked at the skill of the middle managers, the people that we had actually tasked with very difficult jobs, and we looked at the distribution of bell curve, 1 in 10 of those people were exceptional, and 1 in 10 of those people shouldn't have been in the job, and about 8 out of 10 in the middle were extremely well-intentioned people who wanted to do the right thing, and we had not provided the skills for them to do that. And that's really a critically important piece that should be part of the work we do. Next slide, if you will. So we're going to spend a couple minutes on psychological safety. And psychological safety is the comfort level to speak up and voice a concern. And there's a whole spectrum from I don't speak up, I keep my head down, I stay out of trouble, to I speak up if I'm working with the right person. And think about where the real disasters occur. They occur when we're working with the wrong people. You need to be in an environment where A, you know the plan, you feel comfortable speaking up, you know you're going to be treated with respect. And the overwhelming majority of terrible adverse events that occur in our hospitals, when you go back and dissect them, somebody knew something wasn't right, didn't feel right, and didn't feel comfortable to speak in a way that was effective of getting somebody to the bedside. So let's move ahead, and I'm going to let Chris kind of ask you about your experience.
Thanks, Dr. Leonard. We're going to initiate this second poll. That question is, do you know of a patient who has experienced serious avoidable harm because someone was hesitant to speak up? Please take a moment and answer this question. Again, we've got the slides in the handouts pane, and you can ask your questions in the questions pane, which we'll address at the end of this presentation today. Very good. Thank you for those quick thoughts. We'll close the poll and share results. And the results are this: 74% said yes, 26% said no. Dr. Leonard.
Yeah, and I greatly appreciate your kind of honesty and candor, because that's reality. And I've been in audiences where we asked that question, and we did it through anonymous polling, and it was 100% of the people in the room said that was the case, and 2/3 of the people in the room said, you know, that was me. So let's talk about, you know, why this is critically important and what we need to do here. Next, if you would. So one of the things we measure when we measure culture is psychological safety. And again, here we're looking at a very large hospital. We can see some units where 100% of people say, I would speak up, I was concerned about a patient. We can see some places where that's less than 50%. And I can tell you in the HRO work we did in Kaiser, we measured culture across the whole organization, and then we mapped it to what does it look like in high-risk areas like obstetrics and surgery and critical care and the emergency department, et cetera. Because when you have low degrees of psychological safety in high-risk environments, bad things happen. Next slide, if you would, please. So here we're looking at some culture data, and every pair of these bars is about a 300-bed hospital within the same care system. And the light purple are the perceptions of safety of nurses in an operating room. The maroon are the surgeons. And if you look at the left-hand side of this, this is the dynamic you do not want, which is skilled people doing the same work in a high-risk environment, having profoundly different perceptions of what that feels like. And those circle with all those little numbers, those are the never events. So those are the surgical never events that occurred in those hospitals, and all but one of them occurred in low safety culture environments. And in fact, we see time and time again that that a higher frequency of adverse events in low cultural areas. Next slide, if you would, Chris. So again, if we look within an organization and we're looking at units within the same building, we can look for perceptions of teamwork, and we can find that ranges from 22% positive to 92% positive within the same place. And there's a tipping point at 60% when you get to 6 out of 10 people saying it's good here. So just think about, we've aggregated the data below and above 60%. HCAHPS are dramatically different. Medication errors are far more frequent in the low culture areas, as well as pressure ulcers, turnover, employee disengagement. And ultimately, when you talk to these nurses, what they say to you in the low units is, I'm here by myself. I'm just trying to get through the day. I'm here by myself, somebody else to do the dressing change, somebody's turning the patient, et cetera. And that's not the dynamic. Up in the green, I'm here with my friends. We work hard to do the right stuff. Next, if you would, please. So here we're looking at what's called a radar diagram, and this is a hospital with 1,000 people, so it's 0% positive in the middle, 100% positive on the outside. And if you look at 2 o'clock, we've got 30% of the people in this hospital hesitant to speak up. We have half the people at 7 o'clock saying, I deal with difficult individuals on a daily basis. And look at the degree of communication failures at 8 and 10 o'clock. More than half the people say we lose critical information on a consistent basis. So let me hand it to Alan there, Alan, I apologize. I run a little tardy on my end, but I'll leave it to you to finish this up here.
Hey, Mike, no problem at all. So move to the next slide, Chris. Yeah, we just summarized some of Mike's comments. What has he referenced? There are certain behaviors by senior and local leadership that you have to have foundationally, this thing we call psychological safety, and that you also have to have foundationally certain kinds of team behaviors in order to achieve the kind of safe and reliable operational excellence that we are interested in 2018. Let me just add one other picture to that so far and talk about burnout and resilience. Next slide, Chris, please. We know obviously in 2018 that burnout has become this major factor. The measurements in most of the culture surveys are actually measuring gradations of burnout that start off with emotional exhaustion and frustration. In this particular question, people in this work setting are burnt out from their work. The red is bad, the green is good. What you're looking at are essentially hundreds of work settings or departments in this particular view. So those work settings at the top that have 80 and 90% of people responding negatively, in other words, they do feel emotionally exhausted, frustrated, or burnt out, are going to be work settings or units where the fertilizer in the ground for improvement has basically been leached out of the soil because of the way people feel. The healthiest units are going to be down on the bottom, with the rates of frustration and exhaustion and burnout are going to be in the 10, 15, 20%. In other words, 2 out of 10, 3 out of 10, and then you still have at least some foundation for improvement activity. So the goal is to get down to a 20% or 25% level of folks being frustrated. Obviously, you'd like to see even better than that. But what you'll also notice is that in our benchmarks at the top, 27, 43, and 60th, those talk about the 25th percentile, the 50th percentile, and the 75th percentile of the many hundreds of hospitals that we survey. So it's pretty clear that levels of burnout by physicians, nurses, and others is extremely high in healthcare and needs to be addressed. Now, next slide, Chris. So what are the factors that influence burnout and its opposite, resilience? And in the generative organizations, both outside of healthcare well, what we see first and foremost is that people say, I have a voice. In other words, when I speak up, it influences my environment. I am valued by the organization. Mike gave the example of Frank. It was actually Frank Suber, one of the hospitals out in Massachusetts, who knew his personnel so well. Small hospital, he could get around, but you can do it in bigger institutions too. That you feel supported in the work you do, especially by the people around you, and that you have the tools and resources to do your job. And these come directly from Paul O'Neill and the work in Alcoa, the really stellar kind of culture that was created in Google, even with its current dissatisfactions we've seen in the last couple of weeks. I mean, organizations that have been highly successful begin to look pretty similar in what people say about the experience of working within their organization, and these are the ones. I feel valued, I can influence my environment, I feel supported in the work I do, especially by those others around me on my team, and I have the tools and resources to do my job. So then the question is, how do you get here? Next slide, Chris. So Mike and I have been in the business for a quarter of a century of running interventions, sometimes with the IHI, for many years now with our own group, Safe and Reliable Care. One of our certainly significant interventions started at Mayo Clinic, who has done outstandingly good work, and went bunker to bunker. In other words, work setting to work setting, the radiology department to the emergency room to the billing office, both clinical and non-clinical units, where they were leveraging how local leadership and local management empower workers, give them voice, make them feel as if they're cared about and that the people around them care about them, and then layering on that the improvement process. And just to give you some sense of the kinds of things you can begin to see, in units like this. You can look at, one senior surgeon who said to me a year and a half into the effort, said, before we started this program, my biggest concern when I went home in the evening was that I didn't know what I didn't know. In other words, nurses weren't comfortable coming and talking to me about the issues they were running into with the patients on the unit. Now that nurses and staff are comfortable about speaking up about their concerns, I know what I need to know to help the services run smoothly and safely. I go home in the evening with great assurance that we are on track. This idea of people speaking to each other and the comfort level of achieving that in a prescribed manner turns out to be an essential piece of creating the operational excellence that we're talking about. And indeed, you can see significant improvements across the Mayo system on the right-hand side. Next slide. So the question is, how do you go about achieving this? So we've got the framework on the right-hand side. If you were to boil it down, it's got three components: culture, leadership, and the learning system. Leadership is the key component. If you don't have dyad or triad leadership at a local level, and if you don't have governance of this effort at a senior level, the likelihood of holistic change in organizations dramatically drops. If you do, those two groups have to create a culture where psychological safety is manifest, where people feel that they'll be held to account fairly, and where the team behaviors, the briefings and the debriefings are robust, regardless of whether you're talking about home care or the operating room. That foundation then allows you to build the improvement process that you see below in gray. And Chris, you were perfect in changing to the next slide, because if you were to boil down what that improvement activity looks like and the culture, it boils down to the one phrase that you want to walk into units and see that they are self-reflecting and improvement capable. The culture needs to be robust enough so that they do self-reflect, and the improvement capacity has to be robust enough that they can look at their defects, clinical or cultural, and act on them using the appropriate methodologies, lean or the model for improvement and so forth. Next slide. As Michael said, you don't get to pick which of these component parts in this framework on the right are healthy. If any of them is not healthy, just like a patient and digging an organ in a patient, that patient may compensate but will not be as healthy if they've got pulmonary fibrosis or kidney failure or scoliosis or rheumatoid arthritis and so forth. So you want healthy organs around the entire puzzle piece. You don't get to pick and choose or ignore one or two if they're not. Next slide. Conceptually, the way to think about this framework, and we can move to the next slide again, please, Chris, is that every one of your work settings in your organizations, within the acute system, but also heading out into the community and the community of care, is made up of groups of people who come together every day, who define them, the way they define themselves is, I work in the physician's office, the surgeon's office, the booking office, the medical clinic, the operating room, and so forth. Each one of those named areas is a group of people working together that either is or is not self-reflecting and improvement capable. And our interest in 2018, the reason why Mike and I are on this call today, is we have thought for a quarter of a century about what does it take to get a series of work settings to be self-reflecting and improvement capable, and to drive the kinds of changes that we have been seeking for 25 years, or since the early 90s when we started looking at how error-prone healthcare was found to be. And the answer is, you need internally within each of these work settings just that self-reflecting, improvement capable environment, and then the series of work settings that link to each other. In the surgical environment, it would be the surgeon's office, and then the booking office, and then pre-test and pre-op and intra-op and post-op, and then the surgical floor, and then rehab. If each of those is capable, then you are in a position, if you are running a steering process across the surgical service line, to get them to work at the interface issues and then create a surgical surface line that is self-reflecting, improvement capable. Now we're beginning to run a system the way it should. And obviously, same thing if it's oncology or pediatrics or maternity or medicine. Next slide, please. So we've been at this for a quarter century. Let me just tell you some of the caveats in 2018. First of all, if you want to do this across an organization, the senior leadership has to be aligned in its interest. We go into organizations all the time where the chief nursing officer is interested in Magnet. I was just in an organization where their operational excellence group reported to the finance department, and then the clinical leadership, the chief medical officer and the quality safety risk folks were all interested in quote unquote high reliability work. Well, if you've got nursing looking at Magnet, your quality safety risk looking at high reliability, and OPEX being finance driven, you're pretty much in a situation where you're guaranteed to have those bumping into each other and not aligned. So the first piece in organizations is that at a board governance steering level, the senior management has to agree that they are working on work setting development to become self-reflecting and improvement capable, and that it's going to be done in an integrated fashion. So the senior leadership agrees to integrate the work. High reliability and Magnet can be linked, so you draw physicians into the nursing Magnet process the way it should be. The OPEX means process improvement and operational excellence, and systems engineering and human resources folks become aligned with the high reliability and the Magnet effort, or nursing effort, education as the case may be. And then you weave all of those together at the senior level to say, here's the direction we want to go in. The next piece after that is that you look at the dyad and the triad leaders that you have in your work settings. Again, I'm an anesthesiologist, so you take the operating room. The chief of surgery or the surgical director, and the surgical director, the chair of anesthesia, the perioperative nurse director, plus her managers of pre-op, post-op, and intra-op. That group of people, you have to look at them and say, do they have the skill set to be self-reflecting and improvement capable? And have we given them the time to focus on that? Or are they spending the bulk of their time thinking about either payroll, schedule in an academic unit, academic advancement? Because if those are the areas that they're spending the bulk of their time on, the capacity for high reliability is basically nil. And you have to then ensure that the finance office, the academic dean, is not taking up so much of those individuals' times, that material and systems management isn't making it so hard that the managers are always looking for equipment. All of those units, the resource personnel in billing and finance and supply management, they have to be capable in order to give your managers, your clinical managers, the time to focus on self-reflecting improvement capacity. So with the senior leadership doing what they should do, and the middle management effective in running learning systems, you are configured to move your organization forward. But these are conceptually agreements that have to occur at the senior level. They have to be expectations set for the middle management, which includes obviously all of the physician chairs and chiefs and so forth. And then with that in place, you then start the interventions of saying, well, what is your skill set in leading? What's your skill set in team behaviors? What's your skill set in improvement ability? And then you support those managers with the appropriate training to lead well, to create voice, to run briefings and debriefings robustly in ways that are perceived as useful, and then in the defects that are found to apply improvement skills. And if you don't have those at the management level, you'd have to be able to go out to your process improvement folks to say, how do I create this control chart or run chart? What's the best way to show this data? How do I create an aim statement or run a plan, do, study, act cycle? Mike and I have been at this for a quarter century. It is hard work because it requires alignment at many levels and the willingness to then train the middle management in the concepts that Mike has articulated and that I've just described. Our sense is that making visible the activity at the unit level in such a way that senior leadership can also see the activity is one of the component pieces that is required in organizations in order for this to work effectively. We have pictures of thousands upon thousands of physical whiteboards that are inadequate to the task of making culture and improvement visible, and are inadequate to the task of collecting the kinds of cultural and operational data that should inform senior leadership about where to apply resources and what activity to take. We've been using what we call digital learning boards, and just to give you some sense of what they look like, to give you some sense, I think, of what's required in 2018 to move organizations. We'll run through a couple of just examples very quickly. Chris, run through. So why real-time learning boards? You want people putting in issues comfortably that have to do about culture and communication. I did or didn't know the game plan for my patients today. About operations, we have blood pressure cuffs that don't work. About clinical activity, we have 5 obstetricians giving Pitocin 5 different ways. It didn't make any sense, and I almost made a mistake because I had to do 2 types of calculations for 2 different obstetricians. You want to be able to put those in as issues into your learning boards. You want to be able to see the PDSA cycles you're running. You want to make this actually seem as if it is fun because it's their voice, the voice of the front line, having an influence on their environment, which then makes the collaborative effort worth doing, which will indeed decrease burnout and will indeed improve your improvement activity. It then makes workflow intuitive because people get to see it and look at it, whether they're on the unit or elsewhere. Our learning boards allow people to join by video. And underneath the learning boards, there's an analytics suite which allows us to measure degrees of engagement, kinds of issues coming in, and so forth. Next slide. So what do these things begin to look like? Just like the whiteboards, and in the bottom right, you see the little sticky that people would put notes on. So these are notes that go onto the learning board. Anesthesia questionnaire, not easily accessible, ran out of sponges, inadequate restocking, didn't know the game plan, anesthesiologist on call didn't know X, Y, or Z. And you can move these things from new to in progress to completed. You can track them, label them, and so forth. Next slide. All right. You want to be able to see your run charts and your control charts, and you want to be able to link the issues that come in on a daily basis to the groups that are working on the activity. In this case, decreasing decision to incision time for urgent C-sections. But I want to know what happened yesterday that made it difficult to do the C-section. So can I take the issues that come in, send them over to the improvement group for them to look at the end of the week in a way that's meaningful and that gives people voice. Next slide. All right. This is an example of an organization over a period of a year. What you're looking at in the graph is the number of issues that were put in across a whole series of units using these boards, so we can track the activity of the boards. In the top left, you see 59%. We can tell out of 645 users within these various units that 60% of them are engaging with, putting in issues, being responsible for issues, participating in surveys, and we can identify the issues by label on the bottom right in such a way that we can inform senior leadership of where they should allocate resources. Next slide. All right. You want to make these things accessible through all the various varieties of technical hardware that's available, so it's easy to input data and to look at these screens. Next slide. And then use this information when you run your huddles so that huddles become informed appropriately by the kind of real-time activity that issues generate and allow you to see the appropriate run control charts, bar graphs, and so forth as part of your improvement activity that is also then highlighted as part of your briefings and huddles. Next slide. And this just points out what time I have huddles and so forth. So you need to obviously have these team behaviors robust within your units. Next slide. And messaging in order for the appropriate communication from senior leadership to frontline and back. Next slide. So we know that putting these kinds of mechanisms in place can improve management to create the kind of self-reflecting, improvement-capable environments that we're talking about. I would strongly advise those of you listening to be thinking about how to create these kinds of things within your organizations. Our sense is that in order to move our complex environment, especially as they move outside of acute care into community settings, and you're dealing with population health with units that are all the way from the ICU out to home care, that we're going to need an integrated way of understanding issues across the panoply of care, and technology is going to have to help us in that regard. Next slide. So let me stop there. Short of a little bit of time, but happy to take questions or comments from the group.
Thank you, Dr. Frankel and Dr. Leonard. Great material today. Wonderful models, great research. I think the audience will appreciate having those available to them, both as a handout in the PDF form. We will follow up here after the webinar with a slide deck. And for the audience's sake, we have lots of good questions. We are going to go a little over. Before we jump to the Q&A, though, let me go ahead and present one last poll. Let me get that queued up, and then I'll explain why we're doing this. While today's webinar is focused on education, many of you are interested in follow-up from Health Catalyst about any products and services that we do offer. If you fall into that camp, please answer this question. We'll leave this up for a few minutes while we begin with our Q&A. So Dr. Leonard and Dr. Frankel, great questions here. Let me start with one that seems like the easiest to ask. Nurses, physicians, clinical teams are very busy with lots of work. What's one thing they could do today, tomorrow, this week to help them make progress that we've talked about?
Alan, I'm happy to answer. Why don't I let you do that?
I apologize, Mike. I lost for a sec. Would you just repeat the question, Chris?
You bet. And it sounds like we have a little echo. We might have two audios versus Dr. Frankel. So Dr. Leonard, if you could take this until Dr. Frankel's audio is good.
Sure.
Lots of good work going on today.
Yeah, I mean, that's a great question, and it's real, which is we're busy, busy, busy. And the question is, can we create a few minutes every day to get together and think ahead? And can we build an environment? Because all day long you come in and you work around pebbles in your shoes and defects and problems, can't find it, doesn't work, didn't know it. And so it's creating the space to say, can we get together and plan forward? Can we take 1 minute at the end of the day, the end of the procedure, to ask 3 questions? What do we do well? What do we learn? What got in the way that needed to be fixed? And then create a process that we can take the things that get in the way, big and small, to somebody and have a reliable process to say, here's what's getting in the way. Can you help us? Can we fix it? And that's the learning system. And you can start small, but it's the little things that nobody seems to be able to get fixed that drive everybody crazy and deliver this very strong symbolic message of nobody cares, this will never change. So you can do some very simple things, low tech, 5 or 10 minutes a day. And one could argue that if you're huddling effectively, briefing, thinking ahead, your ability to do that work is going to be far more effective.
Thanks for that answer, Dr. Leonard. Next question from Manuela, who made several good comments around this child's fairy tale related to the emperor's new clothes. Lots of adults in the room. Oftentimes the adults aren't willing to acknowledge that the emperor's new clothes really aren't clothing, but he's naked. Who is it in this industry that's there to point out to the emperor that he's naked within the patient safety realm?
Well, I guess I have to do my best guess as to the emperors, but I think let me give you my read, and then Manuel maybe can tell me if I'm incorrect here. So many organizations today are focused on growth and market share and brand, and I understand that. You have to be financially stable. You want people to know you're good at what you do, but the reality is it all comes back to the patient. And if we're unable to deliver safe care and we make decisions that inhibit that or aren't aware of it, there needs to be a way to speak truth to power so we can do the right thing. And certainly what we've described to you and that focus on harm. And there is traction around harm because there's a lot of money involved in that today. That's a way to really ask the question, at least the question I think you've raised, that says, you know, it's not about who's right or who's wrong, but we all agree every patient should get optimal care every day, and there should be no avoidable harm. So let's focus there, and let's continue to kind of move the ball down the field. I think that's the conversation we want to have. And if I completely missed the boat on that, Manuel, please tell me.
I think that's
fully capable of doing that.
Well, thank you, Dr. Leonard. I think that's a thoughtful answer. Just a quick clarification, Manuela was speaking about those who can't speak in English to refer to the clinical staff what their concerns might be. But I think you answered it well. There are a couple more questions. Next question, can you explain or unpack self-reflecting? Dr. Frankel, you spoke specifically about that if you're available.
Oh, sure. Yeah. Okay. Can you hear me again, Chris?
Yeah, better.
Yeah, great. Okay. Yes, let me be very specific about it. You take a group of people, whether it's, you know, the surgical team at the end of an operation, or the, you know, general practitioner with his medical assistant and the front desk folks and the booking folks, as the case may be, in an office practice, and they get to the end of the day, and in some way or another, they come together, and I realize there's challenges in doing that. So debriefing is a process, not an event. You know, so at the end of the operation, it's easy. We'll all stand there. So let me just take that example. What does self-reflecting mean? Self-reflecting means to say, how did we do in this activity that we all participated in? And when we look at and think about how we did, let's think about it both clinically, operationally, and culturally. So it's not just that we did the operation went smoothly. It's also, did we communicate effectively? Was everyone comfortable speaking up during the operation if they had a concern? Did we have the equipment that we needed? And do we think that the operation, you know, went well, was the right operation, as the case may be, given, you know, what we actually saw in the patient? So the conversation of reflecting back, in other words, thinking about what just happened, is a conversation that has to look at clinical, cultural, and operational issues. So the nurse and the MA and the physician in the office practice would say, how did we do in seeing the patients today? Was our communication clear in terms of where everyone had to go? Did we rebrief when we needed to, when things got incredibly busy? You know, I could go on and on and on with many examples in different work settings, but that's what self-reflection is. Self-reflection is looking at what you did with a group of people and saying, how did we do? Did we do it okay? Not just around the operational stuff, but the clinical and the cultural stuff too.
Thank you, Dr. Frankel. Next question. We've got a couple more. I'm working in a very heavily unionized environment for the first time after over 15 years of doing this work in non-union environments. Can you talk about observations and recommendations you can make when doing this work in such an environment? This comes from Carrie Eaton. Thank you, Carrie.
Sure. So let me give you a couple of thoughts, and I want to just give a quick answer to Manuela, which is everybody needs to have a voice, and often we find the most profound insights are from unit secretaries and housekeepers and other people. So the key is you got to get everybody into the conversation, because everybody is smart and everybody has visibility. And if you're not, that's a problem. So I spent 20 years in Kaiser. Kaiser is heavily unionized. There's some places that unions work very effectively. There's somewhere places that's a reasonably adversarial problem. The one place we got very clear traction, this was Doug Bonicum and others' work in Kaiser, was when we linked workplace safety to patient safety. And as long as we're coming to the table and saying, let's play a game, everybody wins. Better care for patients, better work environment for our folks who have what they need, know the plan, feel psychologically safe, feel like they're not at risk. That's the sweet spot in the union environment. And there's a whole spectrum of dynamics, from highly collaborative to very adversarial, but it's really finding that common interest and then, you know, building trust and relationships to move it forward. And it is done very effectively in some places.
Thank you for that thoughtful answer. We've got a couple questions around this last topic, which will make our last question today, related to psychological safety. Can you dig a little deeper and unpackage some of the thoughts around balancing psychological safety with professional tact or practices to interact positively with others?
Go ahead, Al.
Oh, sure. Yeah, I'm happy to take that. Yeah, it's an interesting conversation. Psychological safety says, if you tease out Amy Edmondson's definition of it, I can ask questions, I can ask for feedback, I can be respectfully and appropriately critical, and I can suggest innovative ideas. The overlap with professionalism is professionalism fundamentally is a relationship of respect, or an environment of respect, regardless of position, hierarchy, and so forth. And the challenge that I see much of the time is that people think, all right, psychological safety means I can speak up. Well, then when I speak up, I'm told that I shouldn't have spoken up in that kind of way, or that when I spoke up it was inappropriate. And I think the answer is our expectation of you, psychological safety, especially the third piece, which is respectful criticism, is that when I speak up, I am doing so in service of advancing the teamwork for the best possible patient care, and speaking up in ways that undermine the relationship between the team, that generate rancor between members, is not helpful. So this issue of psychological safety is, yes, you speak up, but you speak up in service of a self-reflecting, improvement-capable environment. And if respect isn't part of that, and if you're not part of pulling the oars in the same direction with the team in furtherance of reliable care, then you're not doing your job. So the job of managers is a tricky one a lot of the time, because you're going to have people who have strong opinions. They may have different opinions than others in the group, and the expectation of managers, of leaders, is that when people express those differences, they do so in a way that's constructive, not destructive. So this relationship between professionalism and psychological behavior, on the one hand, is simple, but on the other, it requires skilled managers to manage well.
Thank you, Dr. Frankel. We have one last question that we want to slip in here, I think, for the benefit of the audience. It's related to patients. We've talked a lot about staff and creating a culture for them to be able to raise issues. What about patients? How do you engage a patient so that they can feel comfortable raising their own concerns or feeling confident in the practice of care given to them?
It's a great question, and I'll give you, Alan, you want to take it, or you want me to take it?
Oh, no, go ahead, Mike.
Yeah.
We're going to say the same thing, would be my guess.
Yeah, probably. So one is, how do we include the patient and their family in the conversation? And one of the things that was done in Kaiser some years ago was nurse knowledge exchange, which is handoffs at the bedside with the patient and their family. And there was a concern of, oh, this will go on forever. And you can frame it. You say, this is going to be a 5-minute conversation. We're going to do a teach back at the end. You've heard us talk about it. Please tell me how you would explain what we talked about to your family. So one is, how do we include them in the conversation in a way that makes sense to them? How do we get them in the room, right? So that we're learning and advising them, so we're having the right conversation in that. We have certainly seen learning boards, digital and analog, in units where patients and their families could enter information. And certainly places like oncology units where people have long lengths of stay. I mean, you could see people reading the boards and entering things and getting feedback. So I think it's absolutely critical. The voice of the patient. Do we have whiteboards in the room? Here are the 3 things you can expect to happen in the next 8 hours. Are we rounding and kind of speaking plain English and really learning whether you understood what we talked about, and how are we engaging them to advise us on the way we deliver care, I think is huge. So lots of opportunity in that regard, but you can see health systems that do this really nicely, but it's key.